Thank you for joining us today as we begin today's conversation, the sex talk. Is it possible to have an exciting sex life when we hit menopause and during COVID? The answers you're going to find out in just a few minutes. I'm Beth Battolino. I'm CEO of Helping Women, and we are the leading national not-for-profit women's health organization that has been creating and disseminating evidence-based health information for more than 30 years. And menopause is one of those topics that is extremely important and relevant to our audience. We developed this roundtable to answer all of your menopause questions and bring you the information that you can use. Before we begin, I want to thank our sponsors. We are extremely grateful to Estella's for their generous support of this roundtable series. And we also want to thank Genev for their support as well. Today is our sixth session in our series of 6. We will be discussing sex and how to be sexually healthy during menopause. We will talk about the changes that take place in our bodies that can affect our sex drive, our desire, and our arousal. Our amazing panel are experts in this space, and trust me, they will gladly answer your questions. So please use the Q&A feature and ask those questions. Now, I'm thrilled to welcome our esteemed panel of experts and today's moderator, Dr. Jessica Shepard. Jessica is an OBGYN and a women's health expert. She is the founder of Her Viewpoint, an online women's health forum that focuses on addressing taboo topics in a comfortable setting. She is also a member of Healthy Women's Women's Health Advisory Council, and we absolutely love working with her on many of our initiatives. Now, I will turn it over to Jessica to introduce our panelists.
Thanks so much, Beth. As you said, this is such an important topic, and I'm so delighted that we have this esteemed panel with us and that I can share as moderator today, because I want women to hear these experts. I want women to interact today as we go through this panel. So we're going to make sure we get a lot of things covered, and we want people to ask us questions. Go to your chat box, make sure that you're asking as many questions as possible. So I'm going to introduce the panel, and I'm going to go across as I see them in my screen, and I'm going to start with Dr. Kellogg. Dr. Kellogg is a nationally recognized expert in pelvic floor dysfunction, vulvar pain, and sexual dysfunction. That is so important, as we know that so many women go through some of these issues and many times don't feel like they have anyone to talk to or feel shame and guilt. So she has also conducted national research trials and published so many studies, reviewed articles and chapters as well. She's a professor at OBGYN at Drexel University, where I did my residency. So we have a very close connection there. And I remember working with her as well, and it was a delight. She's also a certified sexuality counselor, vulvoscopist, and a fellow of the International Society of Study of Women's Sexual Health, which is also known as ISHWS. So thank you, Dr. Kellogg, for being with us today. And then I'm going to go to our next panelist, who is Nurse Dean. I said it correctly. And she is Nurse Barb, and she's a practicing women's health nurse practitioner in the heart of Silicon Valley. She is very well known on the NBC daytime television show California Live, and is a regularly appearing health expert. So I'm very excited to hear all of her expertise today, because she is very passionate about health education. And she really is an award-winning author of the Personal Guides to Health, used by over 5 million women. And she is also the author of 3 books, The Hot Guide to a Cool, Sexy Menopause. So I'm sure that she could share some of those tips with us. And if you need to, go get her book after this so you can continue to learn. And Nurse Barb's Guide to Breastfeeding and Nurse Barb's Guide to Pregnancy. So she's certified by the NAMS and a fellow in the AANP. And I'm excited to hear what she has to share today, because I'm sure I will also learn as well. And last but not least is Dr. Parrish, who's a professor of medicine and clinical psychiatry and profession of clinical medicine at Cornell, Weill Cornell Medical College in New York City, director of medical services at the NYU Presby Westchester Division. And she also is a fellow of ISHWS as well. And she's also part of NAMS and a certified menopause practitioner. So she focuses on sexual health. And the reason why this is so important is because there is definitely a connection between mental and sexuality. And if we have a disconnect between those two, many times you'll find that that's where you have, whether it's dysfunction or lack of function, or whether you just have a decrease in interest in libido. And we'll cover all of those topics today. So thank you, ladies, for being here today and sharing everything that we're going to hear over the next hour. So, I wanted to start this panel out and really just get to just like dive deep into exactly what we need to learn and know. And I just want to understand from your perspectives, each of you, how you feel sexuality when it comes to women in general, whether they're premenopausal or menopausal, what that means, what you've seen in your practice and the women that you've consulted with, why sexuality is such an issue when it comes to women's health. And I'll start out with Dr. Parrish.
So I think this is something that is, well, if we're talking specifically about late reproductive age, perimenopausal, menopausal women, it really is critical to them to continue to feel vital and youthful and engaged, both in terms of their own development and their relationships. And I think when that whittles away, they start to lose that conceptual identity of being youthful and powerful. And it seems very much tied in to also just overall mental and physical well-being.
And what about you, Nurse Barth?
Health, yeah.
Oh, well, I personally found that in my 40s, when I was in perimenopause, all of a sudden I realized, hey, I have no sex drive. And my libido just walked away and it didn't even wave goodbye. And I thought, is this just me? Is this my partner? What the hell is going on here? And I felt very alone. And I also wasn't sure who to talk to, because this is such an area that's shrouded in shame. We're not really sure, right, if our provider is going to have the answers for us. We're not sure how to bring it up. So I'm really happy that we're talking about this today, because what I see with my patients is that they want to know if they're normal and if other women are experiencing this. And I can tell you, you are not alone, no matter what you're experiencing, and you're also normal.
Absolutely. I think that that's so important, that many times when we think of women's health issues, whether it's incontinence or whether it's, anything that has to do with women's health, there is a societal kind of shame. And then many women feel like they're alone. Dr. Kellogg, what do you feel about that question, sexuality in women? You're still on mute.
Is that better? Hello?
We can hear you.
Okay, great. So being a specialist in sexual pain has really opened up my eyes to how many women actually have dryness and itching, irritation, and pain. And moreover, how many people go, oh, well, I'm X number of years old. I've had this many birthdays. It was really nice when it was nice, and now it's not, and I'll just deal. Well, you know what? My message is you don't have to deal. There's so many things that we can do in medicine, but also even over-the-counter products that really help with desire, arousal, orgasm, and pain. So stay tuned.
I can't wait.
Actually, I just want to say, can I just jump in and say one thing? So I want to build on something Nurse Barb said. I think there's a distinction between it being common and normal, right? And this kind of bridges what both Dr. Kellogg and Nurse Barb are saying. So telling women that sexual concerns and questions and even problems are common is it's normal to ask, but it's not normal to accept that it has to stay that way. We don't have to say, oh, this is just normal part of aging. We can reverse that and we can address it, and we can deal and help women have much better function than they believe they have to have, because it's a normal part of aging. So I think we all believe that. And I just think it's important for women to hear that.
Absolutely. And I also think too, that I think many women don't know actually the things that are out there to help them. Many times in my practice, when patients come in with a variety of different issues, whether it's vulvar issues, whether it's pain with sex, and when we go over the options that are available, many of them are surprised that these are available, again, because it's not spoken widespread of, this is available. And also they feel ashamed to talk to their provider about the issue, so they don't know some of the therapies and modalities that are available to help them through these times. And going off of, Dr. Kellogg had brought up the difference between libido, desire, arousal, orgasm. Dr. Parrish, can you briefly explain the differences? And I think that this is an important panel to discuss the differences between desire and arousal, and what the difference is biology-wise, and also from a psychological standpoint, what the differences are.
Sure. So, we could have a whole course in the phases of the sexual response, but, I'll give a brief frame. Many of us maybe watched Masters of Sex or heard about their research, or the Kinsey report, or Helen Singer Kaplan. These are all, famous sex researchers and sex experts. And, they hope to kind of encapsulize, or to sort of help people better understand what they're experiencing during sex, and came up with something collectively, and each of these built on one another, called the sexual response cycle. And the idea is that people move through phases or stages in engaging in a sexual idea or even a sexual experience. That first we have anticipation or wanting, and even as we begin to engage, we want more. And that's typically understood as desire. And the anticipatory piece of that is what people call their libido, right? Because desire can happen when you start. It doesn't have to be anticipatory. So I kind of make that distinction. And then arousal is kind of that bridge between wanting and then engaging and feeling mentally and genitally and extragenitally excited. So it's kind of a transition. You begin to feel engaged, you want, you have a cognitive response, and then your body changes. You get physical changes, your heart rate goes up. We all know the nipples get hard. People start to feel sensations in their genitals. They might get lubricated, wet, and so forth. That's called arousal. Kind of akin to the male erection, but there's much more to it. And I think for both genders, but certainly for women. And then there's the orgasmic response, and climax is another word. Sometimes people have different patterns. They may escalate quickly or slowly, or have multiple orgasms, or feel a gradual sense of pleasure, but not a distinct event. And then in the cycles, which I don't think has a lot of relevance to us as women, is this concept so much about resolution and whether we can re-engage or be refractory. There are biological, psychological, and social contributors to every, and cultural and so forth, to every phase. But typically our hormones play the biggest role in libido and desire, and our neurologic and vascular and even brain functions play a big role in our arousal. And often medications and psychosocial factors and how we're feeling at the moment may play a role in our ability to reach climax and to fully intensify the pleasure of the experience. Those are very loose concepts. And in each of those phases, medications or certain medical illnesses can play a role in how they interact with those biological systems. But that gives us at least a frame for understanding it. I maybe my colleagues can jump in and add anything, but just so women know what we're talking about, and the kinds of ways in which the external or internal states can impinge on or impair sexual response.
Yeah, thank you for breaking it down. Just wanted to say phases. I was just going to go through, you went through the phases, which is important because many women don't know that it's actually in phases, and that allows them, that explanation that you gave, to actually have women explore those phases. So when there's a paucity or a decrease or a decline within one of those phases, they can actually identify it and have better conversation with their practitioners on how to actually address that particular phase, and not looking at it as one like bucket full of just things. It's really actually, you can compartmentalize them, I guess is, a better word for that. Dr. Kellogg, what were you saying?
So it's really interesting because a lot of people will say to me, I think I might have a problem with desire. And when I ask them, why do you think that? They'll say, well, you know what? I used to think about sex, and I used to kind of be an initiator, and I'd think about it during the day and then I'd initiate at night, or vice versa. And now I don't really think about it so much. Pause. And then if I ask them, well, once sex gets started and your body engages and you're kind of in the moment, can you then feel desire? And they go, oh yeah, they'll be like, I want this to continue. This is great. Why don't we do this more often? Oh my goodness. Da, 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 da. And so I think one of the things that's really great for people to know, for women to know, is that sometimes sex isn't static. It changes through our lifespan. And sometimes when sex is initiated and it's very exciting in the beginning and it always predates arousal, sometimes during a woman's phases in her life, arousal will predate desire. And so she'll have to kind of get started. And then once she's started, she truly feels desire and wants to continue. So the phases are there, but they're not always in that order.
And I think that's important too, because that helps with the exploration of understanding the phases. And if, again, going back to if one of them has a decline, how to actually address it, because they don't necessarily have to go in that order. Now, Nurse Barb, in your book, when we were just talking about arousal and desire, and one of the things that Dr. Parrish mentioned was hormones, which we know with menopause, we do see a significant decline in hormones that have a big impact and contributory factor to arousal and desire. What are some of the tips that you have shared in your book specifically for hormones and how it impacts arousal and desire?
Well, I'm so glad you asked, because we're talking about menopause. And as we know, estrogen levels start to decline as women get older. And a lot of women are surprised to learn that they have a lot of estrogen receptors in their vulva and vaginal areas, sort of south of the border, if you will. And that impacts their biology. So my patients are asking me, I don't really have a lot of desire and it hurts. What's going on? And it's very reassuring for women to know it's not you, it's not your partner, it's biology. Because all those estrogen receptors get really thirsty. And I call it puberty in reverse. So things get smaller, drier, tighter. There's less natural lubrication. But through your whole body responds to estrogen and some of the male type, or what we call androgenic hormones, that contribute to desire and arousal and the anticipation and climax and orgasm. Those also can change as we get older. And that's why it's important to be able to talk to your provider. And if you can't, I would encourage women to go on menopause.org or to go to Healthy Women, because there's a lot of resources for women to find providers like Dr. Parrish, like Dr. Kellogg, who can talk to you about options, because there's plenty of options. There are non-hormonal and hormonal, there's over-the-counter. There's a lot of things that we can do to help you have less discomfort, more interest, and be more receptive and have less pain.
Now, you were discussing the estrogen receptors, obviously, which are in the external vulvar area. And when we have a decrease in estrogen, it impacts the tissue and also the sensation. So when we think of like vulvovaginal health, what do you recommend maybe on a daily maintenance routine, or when these things happen, even if people have flare-ups of certain dermatological issues or issues with their vulva, what would you recommend?
I'm so glad you asked. First of all, please do see someone who can actually look at your vulva and your vagina, and someone who knows what they're doing. And I've learned a lot from Dr. Kellogg, though. Sometimes when a person is feeling discomfort, there's no visible changes. So you want to look for someone who has experience with vulvodynia or with pelvic floor issues. But for my breast cancer survivors who are very, very concerned about hormone treatment, they can use vaginal remoisturizers. And I have no conflict of interest. I don't work for any of these companies, but look for something that has hyaluronic acid in it. It's not an acid. It's like a water or moisture magnet. Reverie is one brand that I like. Also, Replens has some. You can go on Healthy Women. You can go look for these in other areas. These are maintenance. These are all the time. And a moisturizer is different than a lubricant. Lubricants are used to slip and slide and make everything really slippery. That's different. So to keep things healthy, we want to use those vaginal remoisturizers ongoing all the time. But of course, don't be afraid of hormonal treatment in the vagina. There's a lot of safety studies that have shown us that there is no increased risk of breast cancer. And we have another, so you have vaginal estrogen, but we also have a vaginal suppository that has DHEAS in it. It's called Interosa. That converts to estradiol in the vagina, and that helps restore all of those receptors, that helps the skin become more fluffy, more elastic, and more able to stretch, so that people can have more fun, whether they're partnered or not. You know, we also don't want women to have discomfort just from wiping themselves with toilet paper.
Thanks. I appreciate that because, again, seeing all the different modalities and therapies and treatments that are out there, I'm sure that there are women who are watching that now understand that they can get that help where they need, whether it's over the counter. But most importantly, you said to have someone look at it initially to make sure there's telling the difference between something that's physiologic change that you would see expect in menopause versus pathologic. And so going along those, as far as like when we think of the vulva and pathological things that can happen, or a pain syndrome, Dr. Kellogg, explain what you would say the difference between physiologic changes versus pathologic changes with the vulva and some vulvodynia, and what that means from a pain syndrome perspective and how you treat that.
Sure, my pleasure. So let's just talk about changes in estrogen first of all. You know, up to 85% of women in the menopausal transition have symptoms of dryness, chafing, itching, burning, pain with penetration, pain with just, or discomfort just with walking and going to the gym and things like that. And that is known in our world as genital urinary syndrome of menopause, or GSM. And that's the new word for like vulvovaginal atrophy or dryness. That is expected, to your point, as a result of estrogen and androgen decrease, which is expected in menopause. But some people, even when they use maybe they go to their OBGYN and they start to use a little vaginal estrogen, or maybe they go on systemic estrogen and they still don't have any relief, no relief of that pain, or they have relief of their daily life is more comfy, but their sexual life is clearly not that. And so they're lost. They're like, well, I did what my doctor appropriately told me to do for GSM, genital urinary syndrome of menopause, but it didn't help my pain. What might be going on is something called vulvodynia. Dynia is from the Greek for pain, and vulva is vulva. And that can actually have many, many faces, but I'll tell you a few of them. Some of the faces of vulvodynia happen because the woman's had an increase in the nerve endings in the vulva. And those nerve endings have grown to the surface so that a soft, soft touch, even with a Q-tip, feels like burning, horrible pain for her. Another type of vulvodynia comes as a result of the muscles that are underneath the vulvar skin being way, way too tight and robbing the area of blood flow. Also just being so tight that they can't allow for a gentle opening that would make penetration and thrusting comfortable. So those are just two thoughts. There's also skin disorders of the vulva. There are many, many things that can happen that aren't just fixed with a little tiny bit of moisturizer, lubricant, or a little estrogen. And so kind of don't take no for an answer, okay? So if you feel like what you've been treated with isn't quite enough to help you, keep looking, because there are answers.
Thank you. That was very comprehensive and robust, and glad that you were able to separate the differences between physiologic, normal, and then some things that are a little bit pathologic, and the difference between pain syndromes and then things that come from discomfort from changes in the tissue. We have a question that was brought in about vaginal suppositories and what type of vaginal suppositories are available, what's in it. You had mentioned Interosa earlier, Nurse Barb, which is actually DHEA, which converts to an estrogen, but there are several types of vaginal suppositories that can impact how the tissue responds. Sometimes they can be with just estrogen. They can be DHEA. Sometimes they are a combination. Now, testosterone is not FDA approved, but there are some compounded ways that you can have testosterone, which is, again, an androgenic form of a hormone. But the best thing I would want someone to do is to make sure you sit down with a doctor to go through all the different types of suppositories that are available for vaginal tissue and pain if you have it, because the real thing here is to make sure that you are a candidate. and to make sure that your past medical history is looked at, make sure that there's no issue that might, again, increase your risk of getting any other diseases. And namely, when we think of that, we usually think of someone who's maybe had a history of hypertension, pulmonary embolism, a stroke, and cancer. And not to say that that's going to rule out any of these options. It just needs to be a discussion that you have with your provider to make sure that you're doing the right thing and that you're doing it under the guidance of a medical professional. So I hope that was able to answer that question that we got. I wanted to move over to you, Dr. Parrish, and discuss kind of when we think of the psychology of sexuality and what that really means with when you have an issue, whether it's pain, whether it's changes in your hormones with desire. What are some things to actually overcome the psychology of it, and what are some tips that we could share with women who are watching today, and men? We might have some men on this call today in this panel, to how to address that so that you can overcome and really address that disconnect that may be going on with the mind versus body. Oh, you're still on mute.
Sorry about that. Wow, that really is a great question. It's also could be a very comprehensive discussion, but I'll try to highlight a few things. I'd like to start with the men. Interestingly, there's been some studies that we've been involved with looking at the male partners of late reproductive age and menopausal women. And the men, and if you have male partners in your life, they are very interested in learning about your symptoms. They don't really understand them, and they want to be educated about the opportunity to help you define your symptoms better and to seek treatment and to know what the treatments are. And some of the things that came out of that research were that male partners wanted to improve communication, not just with their partner, but also with the healthcare providers, and to be involved in the conversation. So a lot of, I think, issues that go on, especially if couples have been in long-term relationships, and in the psychology and the mental state, have to do with communication, have to do with factors in the relationship, have to do with either ongoing or new stressors, or, and there's sort of a typical thing in midlife women, they're stuck in the middle of a lot of forces. They have growing children, and then they have busy jobs, and they're pinnacling in their careers often. They have busy partners, they have aging parents, and then they're trying to answer emails at 5 a.m, or and so they come to me and say, I never want to have sex, or my partner comes to me at midnight and I'm really tired and really stressed and I have no interest. And so I always start with understanding the whole psychosocial circumstances. What factors are remediable to intervention? Is it as simple as, well, have sex in the morning when you're not tired? Or let's communicate with your partner about when yes is a good time. Or how do we come up with some practical solutions to the stressors that are upon you so you feel freer or opened? That said, then there are more complex psychological and emotional factors. Sometimes there are very deep wounds that start to come out as women become more mature, even trauma or long-term hurts or religious messages that have confused them. And as they become more evolved and older and they start to better define themselves, they come out. Or they're facing psychological or psychiatric conditions like depression or anxiety, or having a difficulty with alcohol, or something is emerging that's truly more of a psychiatric problem. So first, sitting, as a clinician, I sit down and try to tease out, is it a behavioral and lifestyle issue? Is it a relational issue? Is it a deep-seated issue, or is it a true psychological or psychiatric issue? And then we can work through those and figure out what factors should be addressed and how. So, it's a kind of a broad scope, but those are places to start. And the last thing I want to say about the psychology of this is that women I really want to re-echo, it's kind of back to this point Dr. Kellogg made early on, is this idea that women don't always start from a position of spontaneous sex hunger, but they enter and want to have sex for other reasons, like they want to build a relationship and they want to be emotionally close. And remembering that hook will help women re-engage. And that's a very important psychological message.
Thank you for that. I think the psychological messaging is so impactful and so important, because many times people think that sex is just kind of off on its own and it doesn't really play a factor in all the different things that are going on in their life. And that's why sexual wellness and sexual health really impact, or is impacted rather, by things that are really going on in our life, which sometimes people can't make that connection, that whether it's where their parents are aging and they're emotionally involved in that, that can affect their sex life and their sexuality and their intimacy. And so that's why a lot of patients who are going through perimenopause, menopausal phase, as their hormones are going down, as they're going through all these different life changes, and then they're wondering why their sexual life is impacted. I think that it's important too, I refer so many of my patients to either a psychologist, a sex therapist, to really filter out, just as you said, those psychological messaging to really help them understand how it's being impacted. We had a question from our guest, which says, can you explain the difference between hormonal therapy in a pill versus hormonal creams? Did any one of you want to tackle that, or I can, whichever one wants to? Nurse Barb, you up for it?
Sure. So there's lots of different hormonal treatment for your whole body for hot flashes and night sweats. And let me just say this. I agree with my esteemed colleagues, Dr. Parrish and Dr. Kellogg. Do see a provider who has experience in this and who will listen to you. You notice that Dr. Parrish is spending a lot of time really teasing out the issues. And it's the same when you think about any hormonal treatment. There's we want to separate facts from fear, because there are a lot of benefits from using hormones. And let me just say this, especially in menopause and perimenopause, one thing that happens is sleep fragmentation. And that means that whether you're aware that you're waking up with night sweats or you're not aware, there's a lot of movement from deep restorative sleep to lighter sleep. And so people may be in bed for 8 hours, but they wake up exhausted. And to Dr. Parrish's point, how can you possibly be interested in sex if you're exhausted? We're not machines. It's not an on-off switch, right? We're so used to everything being immediate with smartphones, et cetera, but you're not a machine. And so everything plays a role here. And I know the question is about hormones, but if you're not getting enough sleep, do talk to a menopause provider about whether this is a good option for you so that you can get more sleep. And also, to her point, relationship issues are huge. And I see that in my practice. A lot of my patients are partnered. They've been partnered for a long time, but they don't like their partner. They've stopped communicating emotionally. And so how can you expect yourself to want to be communicating intimately? And I'll defer to one of my other colleagues to answer more about this.
Yeah, absolutely. I can just give a quick overview of the difference between creams, even pellets, which are bioidentical, and then also pills, which can be taken. Usually the difference when you're thinking of those options are going to be, one, what actually your symptom is. Is it a vasomotor symptom versus it is an issue vaginally with the tissue? And then also the frequency of what you want to take and the dosage as well. How much would think to be needed to adequately address the symptoms that you have. So when we think of cream, which is transdermal, usually you'll find that is going to be taken with less frequency, usually up to 2 to 3 times the most during a week. A pill is usually going to be oral and taken daily. And then if you choose to look into bioidentical hormones, those are not FDA approved, but they have been shown to really help people. Those are usually done insertion and then maybe getting every 3 to 4 months. So it usually, again, revolves around that discussion that you have with your doctor and your healthcare provider. One, understanding exactly what the issue is that you're having and whether that's something that's vasomotor. And when we say vasomotor, that really includes the symptoms that are going to be regulated by your sympathetic system, which is going to be your hot flashes, your night sweats, your irritability, those sleep disturbances that we discussed. And then you also have how hormones regulate the ability for your tissue to be vibrant. And when we think of vaginal tissue changing, it usually will get thinner, a little bit less plump. And you'll find that just like in other parts of our body, when we age, the tissue actually changes as well, as thin, more fragile, and it starts to hang and sag a little bit more. So those also can be addressed with hormones, and that can be addressed whether that's with a pill, a cream, and sometimes even a foam. You can put a foam on the skin and rub that in. And then also with bioidentical hormones in the form of pellets. So again, there's a large variety of different types of hormones and how you treat what you're actually trying to address. What were you going to say?
Oh, I'm so sorry for interrupting, Dr. Shepard, but I want to reassure people that you can obtain bioidentical, FDA-approved hormones that are not compounded. So you can get a prescription that's filled at your local drugstore. You can have bioidentical hormones that are FDA-approved sent to your home. And there is a new tablet. It's called Bijuva, and it combines, right? It combines bioidentical estradiol and micronized progesterone. And as you said, there are creams, there are patches that women can use for their whole body, like you said, the hot flashes and the night sweats. But some people also have a lot of muscle and joint aches. And these are also available. Some bioidenticals are available, FDA approved, for the vaginal tissue. So thank you.
Absolutely.
Can I just jump in with something that might be helpful for people in understanding the differences? So I think it's really important to make the distinction about which menopausal symptoms we're treating. So if you're treating, like what Nurse Barb was talking about, the night sweats, hot flashes, more generalized perimenopausal and postmenopausal symptoms, you might be using something that goes through your whole system, right? And that might be like the bioidentical FDA-approved Bijuva, an oral hormone. There are also patches, sprays, and gels that are either estrogen or combined with progesterone. There's a variety of options that one might need for systemic or whole body hormone therapy. And they don't just come orally. They come in the form of, like we said, gels, patches, sprays, and I think I got it all. If you're treating genital urinary syndrome with menopause, you're using most commonly local therapy. And in those cases, we're talking about the suppositories. There's also inserts. They're kind of different formulas. Some are suppositories, some are inserts, there's creams, and there's a ring even that you can wear for a few months. And they deliver much lower doses, typically of either estrogen or what we were talking about, the DHEA, which combines androgen and estrogen to help rejuvenate the tissue. There's also, not to complicate matters, but there is an oral pill for GSM that only affects the GSM. So I think it's very, very important for women to get clear on what they are getting treated for. And lastly, and I'm sure Dr. Keller can jump in too, the risks are very, very different. The conversations are different if you're talking about treating the whole body with hormones versus just delivering them locally or just in low doses in the vagina and the vulva. And we are really lucky that we have FDA-approved products that are bioidentical and don't often have to run to the compounder. The topic of testosterone or androgens for women is different because there's no FDA-approved products except for vaginal DHEA. So I think we just want to get that clarity because I think people are very confused.
Yeah, I think it really requires having a discussion with your provider who can go through that list. And like I said, when patients come in, we had said earlier, when they come in and I show them all these different forms of what they can take and how it can impact them and what the frequency is, and for their lifestyle, what they want to be able to do as far as frequency or how to take it or what it's impacting. Is it systemic? Is it local? I think that is actually why these discussions are so robust and important. And then carrying that to your physician or your healthcare provider and sitting down and saying, now for me, what would be best depending on what I'm going through, and then also what I think would fit with my lifestyle as far as frequency and how it's delivered. Shifting that to body image and how we feel about our bodies during this time, I wanted to ask Dr. Kellogg, you see so many women that have things that are going on with their pelvis. What have you noticed with your patients that they comment on, remark about, or have problems, or maybe not even problems with the body image when it comes to menopause?
So a lot of women are very aware of how their body has changed over the years. And that means their breasts, their face, their hair, not just their tummy, but definitely their tummy sometimes too. And I find that, they feel like they don't feel sexy, that sexy doesn't come from within because they're being really, really critical of the changes in their body. Now, because I also do therapy with couples, I get to see the other side of this conversation. So oftentimes I'll have a partner and my patient in a room, and we'll be talking about, do you find your partner attractive? What's attractive about them? And I will tell you, 90% of the time, the partner is not saying, oh, that tummy is really upsetting to me, and her hair isn't what it used to be when I met her. Never, never, never. I mean, we look at our partners through the eyes of love. Please remember that. And so partners are not particularly upset about changes because those are expected changes, and they look different too. They look very different often than when they first meet each other. But what I think it's really important to remember is don't be overly critical. That's of oneself. Number two, if your partner is interested in having sex with you, they're obviously not that upset about any physical changes because they're showing you that they're desirous of you. And then the third thing is, honestly, if people are really having problems with, how they look, there's nothing that says sex always has to happen naked. There is no law that I'm aware of, at least, that says you couldn't have a nightshirt or a cute nightie or something like that and have sex with some portion of clothes on. If it makes you feel more free and more sexy, go for it. It's better than avoiding sex, which is what I see, with avoiding sex when people don't feel like they're 100% on their game. The other thing that's important to know is that when women I would say, they change their body in a way, maybe they've lost 1-2 pounds, each is 5% of their body weight, they feel tremendously more sexually robust, and they get a little jolt of desire often. So it doesn't mean that somebody would have to change their body in a huge way, but sometimes just those little nuances really do help a woman with her own body image. I'd like to ask my colleagues, what do you guys see?
Yeah.
I completely agree with what Dr. Kellogg has said. And one of the things that I find with my patients is just a little bit of exercise gets the blood pumping, gets people more interested, sort of on their game, more empowered, more interested. And I like what you say about wearing nighties and enhancing what you feel good about. The thing is that so many partners are just delighted to be invited back to the party. They're not interested in the decorations. They're interested in being together and connecting with you. So don't give up on that just because you're thinking, oh, I'm not perfect. We're always our own worst critics. So please take Dr. Kellogg's advice and be as kind to yourself as you are to others.
And I just wanted to highlight something that Dr. Kellogg said. I feel as you go through those changes, especially hormonally, how metabolically our bodies change, and the sometimes inability to lose as much weight as you had before, how we retain weight after you go through menopause because of the changes in your hormones and your testosterone levels, and even your thyroid goes through some shifts as well. But one of the things that contributes sometimes to how people feel about themselves, obviously society plays a big part in that and what they think we should look like. And also I think that once we do find joy in ourselves and that connection, and that's why intimacy to me is so much different than just sexual encounters. Intimacy is the ability for two people to enjoy their time together, and sexual intercourse is just the actual act of sex, and there's so much more than just that, and intimacy plays such a big part in that. We had a question actually from the audience about women who, obviously we know that childbearing age has moved or shifted a little bit more into later 30s and 40s. So for women who have put off having children for a little bit later and have their children maybe in their early 40s, after they now are going through perimenopause and then quickly into menopause, and now they have younger children during those timeframes, what are some ways that they can have or what would you recommend as far as input on sexual activity, sexual intimacy for women who are going through menopause with younger children because they had children a little bit later on in life?
I would say make time. That's the one thing I will tell you. We've all had kids, I think, on the panel, but I will tell you, when kids are small, whether you're in menopause or perimenopause or any time, the natural priority will go to child care and making sure that those kids are safe and they're well educated. But part of kids, part of being a family is really to have everyone pretty much connected in that family. And the one thing I will tell you is I see that women are not honestly prioritizing time with their partner. They're not finding time to be with their partner. And so long periods of time go by when intimacy isn't taking place. And they don't feel good about that, but they don't know how to undo it. So sometimes it's just as simple as making a date, putting it on a calendar. I often will say to a patient, have you missed your son's soccer game? When was the last time you missed a soccer game or a piano recital? And they're like, oh, no, I leave work early. I do what I need to do to get there. But kind of what they don't have on that calendar is time to be with their partner. And that doesn't have to mean, to your point, Dr. Shepard, it doesn't have to mean penis and vagina or vagina and vagina sex. It could be certainly a dinner out with just the two of you, or just some time, have a little picnic in bed some night, and just really have time together. 20 minutes is usually all it takes to kind of reestablish that bond and make sure that all the attention isn't going just toward, the frantic lifestyle and not toward the primary couple.
I had heard a comment that a sexual medicine colleague of mine made at a meeting when he was talking about what he says to couples. And he said, and at first I had mixed feelings when I heard it. He said, make sex a priority, have sex once a week, even if you don't feel like it. And then, when he talked more about it, it always stuck with me that it's what Dr. Kellogg is saying and Nurse Barb is saying, is that you have to just say, I'm gonna make time for this. And once you set the stage and you do the things that will bring you to more enthusiasm and feel more desirous in the moment, you'll enjoy it and you'll connect. And just planning to connect is really what he was suggesting. I do want to make one very specific comment about this age group. So when women have children in the later part of their reproductive life, they may be transitioning to some of the changes of perimenopause. Peri means kind of around. And it's not just a moment, menopause, it's a process. It can take place over 5, 7 to even 10 years. And so people confuse like, oh, I have small kids and it'll get better when they're a little older, with the physical changes that may be starting to occur. And teasing that out in a dialogue with your doctor. So, oh, maybe I am feeling a little lower desire, or feeling dry, or, or so some of the other medical problems that impair hormones or neurovascular responses might be creeping in. So the key is to, when you try to tease it out for yourself and talk to your provider more about what you're experiencing. I want to say one other thing about body image. I thought about it after we kind of ended that topic. One thing that I've been seeing in the time of COVID, love in the time of COVID, is that women are saying, I'm spending so much time with my partner, but I'm having less interest, and I think a lot of us are stressed by the pandemic. By all the worries that we have, whether it's financial or our kids are now home from high school. I have that problem. My seniors should be in high school, not bothering me all day long about the dog. They're very stressed, but they're also not doing the things that they do to make them feel good. So, and women are feeling guilty about admitting this. They're not coloring their hair. Maybe they're not getting their Botox. They're not getting to the gym. And that doesn't make them feel the sense of sexiness that they feel. And giving people permission to do those things or work around it or find ways to feel good, even in lockdown or a different mode, really, I found has been empowering to women and to help them identify that. I really have seen this over and over, especially as time goes on in recent months. I don't know if you've had the experience.
No, thank you for all of that. We are 10 minutes away from ending this panel and we are getting some really good questions in. I want us to all give a quick answer for this next one, which I think is so important because as we know, breast cancer affects 1 in 8 women in their lifetime. And that can be sometimes very traumatic to women, especially when we think of sexual health. So there was a question that wanted to ask about how to get your sexual groove back after a breast cancer diagnosis, because that one can impact body image if there was any surgery done, but also from a hormonal standpoint, if there's any chemotherapy or radiation, which can change the hormones. So each of you, if you could give a quick answer or tip for the person who asked the question about getting your sexual groove back after a breast cancer diagnosis.
Okay, I'll start. Dr. Kellogg said this very well. Don't give up. If you're not getting the answers from the provider that you're seeing, don't give up, because so often I'll see someone who's been seeing their oncologist, and their oncologist is very focused on chemotherapy and radiation, but not necessarily on keeping everything feeling moist and the vagina. And remember, sex is not just about penis in the vagina, penis in the vagina. Intimacy, as you said, Dr. Shepard, is so much more than that. But make sure that you are not suffering from all the night sweats that are keeping you up at night, and make sure you keep your skin integrity healthy. And there are lots of options that will not put you at risk.
I'll go next. One of the things that actually blew me away when I read the statistic is that the mean or average amount of time between the day of diagnosis and resumption of regular intimacy is 18 months. And understood, there's lots going on during that time that sometimes intimacy isn't right at the top of the list. But I'd like to point out that 18 months is a long time, and it's a long time for dryness to set in, for changes in the tissue to set in. And something that I see all the time is that because of lack of use, for better terminology, in the vagina, or lack of stretching in that vagina for that long, the muscles that I made reference to a little bit ago, they do start to tighten up. And so patients will say, wait, I had breast cancer that affected this part of my body. Why is that part of my body not working? It doesn't compute. And so I'd like to encourage patients to, if things don't fit or feel like they fit, be sure to look at the skin texture and integrity and the moisture, but please have a provider or you look to see if the tissue is able to stretch and if the muscles are able to relax and allow for a comfortable penetration. Those are things that are not hard to rehab. And I think while we're on this topic, we should talk about dilators. Dr. Parrish.
So I'll bring up dilators. So that's not hormonal, and it doesn't have, any really downside as long as you're instructed and you use them properly, and it can really help stretch tissue. And this is particularly an issue for women who are hormonally depleted by treatments for breast cancer. They can also be useful for other, for other postmenopausal women who have tight tissue. And you can learn to use them on your own, but you can also find a provider who can teach you and educate you about how to integrate them. And they really help. They prepare things, and they can help also, as you're reintroducing sexual activity. My comment to women who are dealing with breast cancer is partnered and unpartnered women, don't forget about the importance of pleasure and nurturing, physical nurturing. So you don't just have to be touched genitally. There are other parts of your body that can feel nourishing and erotic. And then the second piece for anyone is to communicate to who's ever going to be with you intimately about what you need and want and how you want to be touched or held. And that may reintroduce intimacy, and it may or may not be, classic sex, but it will restore and help move toward what you ultimately want to resume.
Absolutely. Let's see, we have 5 minutes left. We did have one question regarding the thyroid gland in menopause. And so we know that incidence, obviously, when we think of thyroid disorders and diseases, that's going to predominantly affect women, and their incidence is much higher than men. And you'll find that you'll accumulate or start to have thyroid changes or diseases as you age. And so quite typically, when you start to see hormonal shifts with your sex hormones at menopause, you'll also very often start to see changes that will happen consequently with the thyroid gland. And so that's when you're going to see that impact with whether that's metabolism, whether that's sleep disturbances, heart palpitations. It contributes to also the vasomotor, hot flashes and sweating and insomnia. So those are going to be very common when we think of thyroid and ovarian dysfunction and changes that occur with menopause. So that's why it's very important when you do discuss these changes with your physician or your healthcare provider to make sure that that's brought into the conversation. Many times that can go missed. And there are things that can actually help restore your thyroid as you're going through some of these changes. And you just don't want to be, you just want to make sure that you're not so tunnel vision to looking into sex hormones that you forget that actually there may be some changes that are going on with the thyroid because they do have a lot of overlap when we think of the symptoms. And we definitely wouldn't want anyone to kind of miss that. Now, there are women who are on thyroid medications, and as they go through menopause, they'll start to see that there will also be a shift in which they either have to upregulate or downregulate some of their medication. So it is very important that we pay attention to that, make that part of the conversation. And again, that's something that what we were discussing earlier in the conversation, normal versus common. It's very common, but we wouldn't want that to be your norm of a disruption with your thyroid. So I just wanted to make sure I made note of that, that we discussed thyroid in this, and it actually was a question that someone had brought up. And then I think I'll end with our last question. If each of you can give your advice, that this was a question that came to us, how can we find a healthcare provider? And we've been alluding to this throughout the entire discussion, a healthcare provider that specializes in midlife health, especially when it comes to sexual health. I'll start with you, Nurse Barb.
Well, I would encourage everyone to go to menopause.org to find a certified menopause practitioner. And you can also use the ISHWISH, International Society of the Study of Women's Sexual Health. There's a National Vulvadinia Association website. There's a pelvic floor physical therapist website that you can find providers. And again, to all of my panelists' point, do not stop. If you're not getting the answers that you need, search further for someone who is going to listen to you with their 2 ears, right? 2 ears and 1 mouth, and then provide the options, a menu of options that will work for you. And thank you again.
Thank you. Dr. Kellogg, can you give some insight onto what you think would be a great resource for women who want to find this, and also some tips, some maybe like one important question if they were to go to a provider to ask them what's important to bring up in those discussions?
You can ask them if they see a lot of midlife women and if they are comfortable talking about sexuality, because honestly, some providers are not. The other thing, I have to give a plug for allied health care providers like nurse practitioners and nurse midwives. Often they will have a little bit more education in sexuality and a little more inclination to spend and sit with their patients and really talk about sexuality in depth. Not that physicians don't, please understand that, but I will tell you that a lot of my patients are pretty happy when they see nurse practitioners and nurse midwives who specialize in menopause.
Thank you. And Dr. Parrish, I know you're with NAMS, so can you let the crowd know what NAMS is and how that actually is very helpful when we think of menopausal phases and sexual health?
So NAMS stands for the North American Menopause Society, and it's a wonderful multidisciplinary organization of allied health professionals, nurse practitioners, endocrinologists, internists, gynecologists, many people who care for women. And the focus is on the menopausal stage woman or the midlife woman. They have wonderful consumer resources. They have a Find the Provider website, which Dr. Barb mentioned, and they have a number of other community videos. There's a lot of resources. And I find great collegial connections and resources when people ask me, do you know a doctor or someone to care for this patient in Dallas or in Silicon Valley or in Philadelphia? So I encourage you to look at their website.
Thank you for that. And with that, we are going to conclude this panel. I really want to thank Healthy Women for finding the importance in this topic and allowing such esteemed panelists to be on this. And I really do hope that everyone has learned at least one thing today, if not more, and that they can share this information with everyone and make this part of conversation topic so that it's not uncomfortable anymore. And the more that we start to have these discussions, the less shameful that women might feel, or any guilt. But knowing that sexual health is such an important part of who we all are, and a complexity in our diverse crowd of who we are, and knowing that menopause is a journey, and that it doesn't have to be sought or looked at as something that's completely horrible, but something that can be enjoyable. And if you have any further questions, please let us know. You can find out where we are and contact us directly. And to Beth, thank you for having such a wonderful discussion and allowing us to be part of it. And with that, thank you to our panelists, Dr. Parrish, Dr. Kellogg, and Nurse Barb, for being here and spending your time with us so we all can invest in our health. Thank you so much.